Welcome, ladies and gentlemen. Thank you for asking me to do another one of these sessions, and I hope it's useful. In my normal vein, I haven't done loads of slides because I do think that this is more important to discuss rather than me presenting loads and loads of information. So I'm just going to give you the top lines of what we're up to. It certainly does not embody everything. So the title was Research and Clinical Trials in TTP, and I am obviously going to just relate this to the UK. So I found this, and actually it should be the top 6 reasons why clinical trials are important, because it was from a paediatrician. So the last bit was involving doing clinical trials in children, but I've taken that bit out. And these really are the reasons why we do them, because the results can affect more patients that are just within the trial, both positively and negatively. So it's important sometimes to prove that a treatment which we think might be useful, actually it turns out not to be so useful, and then it isn't given to many more patients. It allows us to bring new treatments to market, and I'll talk a bit more about that very shortly. It provides very good information because it's very structured, and we have to keep to the protocol. Sometimes the protocols are amended, but it is a structure that we have to follow. So theoretically, everyone should be the same within the study. Most of the studies start with early phase trials, so phase 1 or phase 2, to make sure that the treatment that we're going to use is both safe and effective, and then won't move on to bigger phase 3 trials, which is what we use to market drugs, until we can prove these first 2 points. And it takes out a physician's bias. As I said, we think sometimes the treatments are going to be good, but unless you do it in this blinded way, so you either give a patient a dummy drug or the best comparator and the new treatment, we cannot otherwise prove that it is fit for purpose and ready for the clinic. So all of this started for us really with the UK TTP registry, and the first patient was recruited onto that in 2009, the 1st of January 2009, this went live, and it's still very live. And it's a very, very important resource for a number of different reasons, which I hope to share with you this evening. So what it originally set out to do was to capture all the acute cases of TTP in the UK. And that was primarily immune mediated, the antibody type of TTP. And it was at a different era, at a different time. So we wanted to see the number of cases that were in our great country, and if these were increasing, decreasing, if there was any associations. So obviously it's all acute TTP cases, and with time it was evident that it wasn't just immune mediated but also congenital TTP, which I'll explain a bit more in the next slide or two. Since 2018 we made an amendment. So there's many amendments that have to be made with any study, but this one was a big amendment, and what we wanted to understand is what happens in the longer term. So now, if patients consent to be involved with the registry, we will determine what's changed in the last year. Have you had any new diagnoses, any new drugs? And we do these yearly assessments, and they're called TYM and PHQ-9. And I don't know if you have done these or if you know what they're about, but it's 2 of the, or 3 of the frequent issues that are that come up time and time again. One is testing your memory, and there's no right or wrong. It's about looking for trends, because actually it may well be that if you stay in a good remission over time, that will start to improve rather than having recurrent relapses where it can affect your memory time and time again. And PHQ-9 is very important, and in fact has been extremely important in how we manage patients. It looks at anxiety and depression, And obviously that can change with different circumstances. Initially, it can be because of the TTP. It can continue on because of the TTP. But for example, more recently in the ones we've done, we've seen some patients where it's really quite high because of social isolation. So we need to help to manage that. So one of the other important reasons for the UK registry is in relation to the TTP National Service, which is going to go live very, very soon. And that probably is a whole topic on its own, but essentially it's ensuring that there is a regional central hospital that looks primarily after patients with TTP at all times. So rather than multiple hospitals. Now that doesn't mean that you can't still go to your local hospital, but it has to be joined up with these regional centres. So what has the registry achieved over these years? It's generated a massive data set of information. You all know that you're very rare and you can't really present a decent amount of information or 10, 20 or 30 cases, even though that's a large number of TTP patients. And what it really requires is tens and hundreds of patients, which we've achieved over that time. But more importantly, or as importantly, is that we have samples from patients, both when they were admitted and at follow-up, and a sample to look at genetics. It's generated some really important publications. So when we do ask you to be part of these research efforts, even though it doesn't involve drugs, it's really, really important for us to understand information about different aspects of the disease. And I'll show you some of those in a minute. So it's been adapted for the needs of the condition. So now the longer term follow-up, and it can be adapted and will be adapted even more, particularly I think over the next year or so. It's provided a platform for research trainees, and that is really important because we need to ensure that there are a future cohort of doctors that are going to take on TTP or related conditions. So they have access to the registry, if that's what their project's about. They have access to understanding how clinical trials are run. And also, certainly in our institution, you will see from every few years there's a change in personnel as new trainees come through. And it's also been a source for national policy. So let me just run through a few of the publications. So these are only a few that have come from the registry. I don't know, and I don't expect you to know, the hierarchy of where we publish information, but the journal Blood is probably the highest impact factor for haematology. And we've been very fortunate to get a number of papers, because they're so important, the information in them, into the Blood journal. So one of the first ones from the registry is this one here. I don't know if you can see my mouse, but it's the one looking at pregnancies. And what happened over a number of years, we realized that the ladies who presented with TTP in pregnancy weren't all immune-mediated TTP, which is what one would expect. In fact, there were more patients that were presenting in pregnancy for the first time with congenital type of TTP. So this paper describes that phenomena, and it also describes what happened to the ladies before they were diagnosed and what's happened after they were diagnosed. Because for many years it was considered that pregnancy was not an option in patients who had TTP. And so not only were we saying, actually there's more of these ladies have congenital TTP, but subsequent pregnancies are completely feasible. And this is how we've done it successfully. One of the more recent ones is down here on the right-hand side corner. And again, a very, very important piece of work. So it's looked at all the congenital TTP patients in the UK. And it's really the biggest paper, in conjunction with colleagues who presented it from an international registry, on understanding what happens. It really wasn't out there in a big number of patients for you to make proper conclusions. But our paper and the international registry really has changed how we consider presentation, treatment, and follow-up. And as many of you that have signed for the registry that have congenital TTP will have been involved unknowingly, possibly, in this paper. The top one on the right-hand side is looking at your samples and also your clinical information. And it's looked at hundreds of patient information, specific information, primarily the troponin level, your Glasgow Coma Scale, which is a very quick, you know, are you conscious, unconscious, stroke, things like that, and compared it to the levels of your antibody to ADAMPS, your ADAMPS13 antigen, which is the amount you produce, and the activity, which is the amount that's actually working. And we were able to dictate what the prognosis of certain features are, both clinically and comparably to what we see with these blood tests. Again, a very, very important piece of work. In the middle here is one looking at rituximab prophylaxis. And many of you may have had this in the past or recently in the hope of preventing a TTP relapse. And we've been doing this for a number of years, particularly in the UK. And this is just demonstrating the importance of it, but looking at certain comparators. So what's the best dose? How long does, if you give a lower dose compared to the normal dose or a middle dose, how long do patients last before they need further treatment? Are they well? Does it normalize the ADAMPS13? And the final thing that we did a quick look at, which was again very important, is using just the basic ADAMPS13 testing to help differentiate TTP from other conditions that might look like TTP. And this is really important so patients get the right treatment and to prove how important this assay is. So this is my diagram of TTP. So these are the big long strings of von Willebrand factor, and we need a scissors to break it up, and that scissors is ADAMPS13. And when we break up von Willebrand factor, its action with platelets is to prevent damage and prevent bleeding. So in TTP, the enzyme isn't working. And this is in the majority of cases because of an antibody. And this results in the big long strings of von Willebrand factor not being broken up. So your platelets bind to it more easily, more avidly. So when you come in with a platelet count acutely, let's say of 20,000, it's not that you don't have platelets, they're just all in the wrong place. And the result is that these break off, and this is what causes the symptoms and signs that you may have. And that's why sometimes the symptoms and signs can wax and wane a bit, because they break off and then they dissolve and then they break off and cause more problems. So currently the treatment we use is plasma exchange. And the reason for this is to replace this missing enzyme. But this only works for as long as you're giving the plasma exchange, and a bit longer, obviously. So what we also need to do is get rid of these antibodies blocking the ADAMPS13, or in congenital TTP, just replenish the ADAMPS13. Congenital TTP do not have these antibodies. So that's why we use steroids and rituximab. So we've been using rituximab for a very, very, very long time in the UK since about 2003, 2004. So really early doors. And we've been able to show repeatedly, as have many other colleagues internationally, the importance of using it in patients that have refractory type of TTP and those that have relapsing type of TTP. And here we did a study many, many years ago using rituximab pretty much as soon as you come into hospital. And that's pretty much standard of care now. And we then did some work to look at, because there was often a lot of argy-bargy arguments about the right timing, about why we use rituximab early rather than later on and waiting for patients to become refractory. And I'll show you that very shortly. Well, in fact, I'll show you now. So this was some work that J.P. Westwood did. And what it shows is if we give rituximab within 3 days of coming in with acute TTP or after 3 days from admission, you'll need less number of plasma exchange if we give it early, which I'm sure that you will all confirm is the way forward. Your time in hospital is less. The time to you achieving a complete remission, that is normalization of a platelet count, is much less. But the really important thing is that it takes about 10 days for the rituximab to actually work. So if we give it on day 2, it's going to be at least 10 days later until things really settle down. So the reason for giving it earlier is because we know it takes about 10 days. But if you wait and to see if a patient is going to become more difficult to treat and their disease is more refractory, or they keep dropping their platelet counts, you've kind of missed the boat a bit. So over the last few years, we've been quite busy internationally, but also in the UK, recruiting to 2 studies, which are now completed, and they're very important for you to know about, and many of you will have received these treatments. The first one was called the Titan study, and it was a phase 2 study. So it was looking to see if this drug was going to be effective and if it was going to be safe. And the results from this, which was a very, very long study because of the way it was developed, was that it looks effective and safe. And then we went on to the Hercules study, which involved many more patients. And this was the phase 3 study. So you either received this drug called caplizumab or Caplevy, or you received a dummy injection. And we didn't know, or none of the investigators were allowed to know which one you received, because otherwise the results and the way you treat patients could be affected. So this went on for about 18 months. So it recruited very, very quickly. And this is a summary of the results from the study. So the patients in blue are the ones that received Capla. The patients that are in red are the ones that received the dummy drug. As you can see, to begin with, both of the platelet counts were comparable, whether you received a dummy drug or the caplizumab. And that's because when you come in, the treatment is really, really very intensive. But then you've got this period, again, about 10 or 15 days, where there is a marked difference between those who received Capla and those that didn't. So this is comparable to the time it takes for rituximab to be effective. And in the placebo group, the dummy group who just got standard of care, it's not that they don't normalise their platelet count and can't achieve a complete remission. It just takes longer. Whereas with Capla, it was really very quick. So the platelets normalised much quicker. And not only did the platelet count normalise quicker, it stayed normal while we were trying to sort out the underlying disease. By about day 15 or 20, both groups have a normal platelet count. As you can see, even within the study, patients did still die, unfortunately. Thankfully, there were none in the UK. But in the Capla group, none of the patients passed away. In the placebo group, it says here, exacerbation of acute TTP, and what that means, and I'm sure many of you pre-Capla will remember this, your platelet count normalizes, and then after about a week, or sometimes sooner, or sometimes a bit after that, your platelet count starts to dropping again, and all the treatment needs to be intensified. And sometimes it can drop very low. So that's what we call, and that's what we mean by exacerbations. So the patients in the placebo group, nearly 40% of them had these exacerbations, where it was very uncommon in the Capla group. So what happened in the study? If patients had an exacerbation, they just received open label Kaplan, because it's not very ethical when you know that a treatment works to withhold it. But it was important to capture the number of patients who had this initial exacerbation. Then we look at what we call relapses, and that's anyone whose platelet count dropped 30 days after finishing plasma exchange. So from the original study, we continued with the Kaplan for 30 days. And in the Hercules study, we could extend that. And we extended it by 4 weeks, working out a week at a time if we needed to keep going. And what this does is provide, again, really important information. So there was no relapses in the placebo group. So the placebo group did very well. But there were 6 patients, or nearly 10% of patients in the caplacizumab arm who did relapse. So what this is telling us is that we've helped to keep the platelet count normal and the patients are safe, and we can prevent the ongoing little blood clots that I showed you earlier. But the underlying disease hasn't been hit. So the relapse rate was much higher in the Titan study than even in this study. But it means that the ADAMTS13 is still very low, and we need to increase the amount of immunosuppression to get rid of the antibody and normalize the ADAMTS13. That's quite a lot of information on that slide, and I'm happy to go over any of it if any of you want me to afterwards. But this is also from the same study, and this, I'm sure, is something that you can really relate to. This looks at what actually happens to you. If you receive caplacizumab, the number of plasma exchanges are significantly less compared to the placebo, and therefore the volume of plasma that you receive is significantly less. The number of days in intensive care is way lower in the patients who receive caplacizumab compared to nearly 10 days for those in the placebo group. Just be mindful that not everyone manages how patients and where patients are treated the same. So in some centres, all patients with TTP go straight to ITU. We don't always do that. So some of our patients don't need to go to ITU, about 50% do. But even given for that, that's a big difference between the two. And as you can see, the number of days in hospital is reduced by about a third. So normally it's about 14 days, which is placebo arm, and that's what we have historically from all the data we've produced and other centres have produced internationally, and that's reduced down to about 9 to 10 days. So now the picture gets even more confusing. So we have the recombinant, we have the plasma exchange to get rid of to replace ADAMTS13. We have the steroids and rituximab to get rid of the antibody. And now we have this drug, caplacizumab, which binds to the von Willebrand factor and doesn't let the platelets bind to it. So it means your platelet count goes up really quickly, and you stop producing these little thrombi which cause all the clinical problems. So it's not over yet. What we did a few years ago was look at something called recombinant ADAMTS13. And this is being looked at in congenital TTP, where they just need to replace the ADAMTS13. They don't need to get rid of antibodies. So we'd already done some work, or comparably, or actually it was since then, we did some work to see how high the ADAMTS13 goes in patients with congenital TTP who are getting regular plasma. So their treatment's somewhat different to patients with immune-mediated TTP. They get regular plasma infusions. And in general, we can increase the ADAMTS13 level to about 30–35%. So this was a phase 1 study. It was the first ever in man. And there was a few patients from the UK that were involved in the total of 15. And they got 1 dose of the recombinant ADAMTS. And as you can see from here, from less than 5%, it went straight up to over 100%. Well, it's about 100%. So really, really good. So it's just the pure enzyme. And this is not abnormal for us. We use factor concentrates for many types of conditions. So having it just to replace what's missing in TTP obviously makes perfect sense. And as you can see from the next studies, we are undertaking studies internationally in patients with immune type of TTP. We're currently doing a phase 2. And thankfully you're all on mute because I'm sure there would be a big shout out, but would you like to have 2 vials, possibly 3, which is about 15 mils of fluid just put into your vein, which is comparable to a whole plasma exchange, which is 3 to 5 hours with the central line. That's the difference that we're talking about. So there are some studies that are currently ongoing. The first is in congenital TTP, and it's using the recombinant ADAMPs, where the patients either get their standard of care for 6 months and then the recombinant ADAMPs for 6 months, or the other way round. And this is a phase 3 trial. So we hope when this finishes, we'll be able to then, or we won't, but the company will then bring the drug to market. At the same time, we're doing a phase 2 study in patients with acute TTP who come into hospital, and we give the recombinant ADAMPs, but in conjunction with plasma exchange. It's an early phase trial, so it's a phase 2, but the subsequent ones, if it looks safe and effective, will hopefully just allow us to use recombinant ADAMPs, which may mean that we won't need to do days and days of plasma exchange. The Hercules study is the one using caplacizumab. And after patients had finished their acute TTP episode and their treatment with Capla, they then went into a follow-up study, which is very, very important to understand information, a whole breadth of information, including looking at how often patients relapse, and if they get further caplacizumab, does it work as well? But also looking at a number of parameters that I know many of you in particular consider very relevant in the longer term, such as lethargy, how you feel, memory. And for those of you that have done this, there is a particular session that you've got to do, something called R-bands, which thankfully I don't have to sit through, but one of the registrars does very kindly does for me with the patient, but it's really hard going and takes some time, but also follow-up questionnaires. And the final study that's currently involving a medication, a drug, is the elective rituximab study. And this is in the UK. And Mari Thomas, one of my colleagues at UCH, is actually in charge of this. And what we want to do is look to see which dose of rituximab, when we give it to you to prevent relapses, is going to be effective, or the most effective, without having side effects. So we're using a very low dose and a standard dose of rituximab. And that's recruited very well in a number of centres. So even though we use rituximab for many years, you have to do a comparator study so that it's evident which is the best of the lot. I've lost my arrow to move on. Right, that's all that I'm going to present, and it's a massive overview. It does not take into account many of the other laboratory-based research projects that we're undertaking, both in the UK, in our centre, but also internationally. I've got my headphones in, so I can't hear what's going on in the background, but I'm unmuted and my dogs are playing and they're going to bark any minute, so I do apologise. But here are some of the questions that have already come through. So I'll run through these, and then if there's any further questions that come through on the chat, I'll aim to answer them if I can. So one of them was looking at COVID-19 causing blood clotting, leading to increased blood clots, which is very, very true, and whether vitamin K would be useful in regulating the clotting pathway and protecting against lung disease. I'm afraid no is the answer to that. It's not that type of blood clotting. It's the result of having a very inflammatory state when patients come into hospital, and it's usually those with very severe COVID-19. And it's not dissimilar in some ways to the very severe inflammatory state that TTP patients have, in as much as you're sitting for a long time having plasma exchange, you're on a bit of steroids, you generally get dehydrated, there may be nausea and vomiting, and all of those result in risk factors, and that's why you get injections to prevent against blood clots, but we don't give you vitamin K. This one is a little bit more interesting about patients who are deficient in vitamin D and the risk of COVID. I'm not sure that there's any good trials to suggest the association. I think it's very difficult, but having vitamin D is not going to do you any harm and is not contraindicated in TTP. Connections between TTP and other autoimmune conditions. So this is an important area. TTP in the main is autoimmune, immune mediated, and some patients who have other autoimmune diseases can present with acute TTP. It does not mean that everyone with TTP will get another autoimmune condition, but we do now, we check when you come into hospital, and we're now doing a yearly check as part of the follow-up. So sometimes there are some patients who develop a lupus type TTP, but it's not in a high proportion of cases. And generally it's about a 10 to 15% crossover. There was a question about rituximab in a tablet form given on the back of Tina's webinar. I'm not sure what this was actually about, but rituximab is not available in a tablet form. You can get it as a subcutaneous form in some hospitals, but not as a tablet form. And finally, how the caplizumab trial's going. Well, the trials are finished. Caplizumab is licensed and it's currently going through NICE, even though as many patients we can give it to in the last 2 years have had it. We do need to get it authorised by NICE and paid for by the UK. Well, that's the end of my slideshow. So that was all I had. And let me just see if I can.
Shall I read out the...
Oh yeah, read them out.
Shall I read them out? Because I've saved them and there's just one more that's popped through. So if we just add that to my list. We're going to talk a little bit about NICE and the what's happening with that just after we've gone through the questions. I'm actually going to leave the video recording because I'm not going to put names to the questions. I'm just going to read them out, and therefore they're kind of anonymized. And I think that might be quite helpful for people who are viewing it in retrospect. So the first question: is it true that it's safe to have a vaccine with a dead virus but not with a live virus for TTP patients?
Yes, so things change. The dead viruses or the live attenuated ones are probably all okay, actually. We were a bit worried a number of years ago that the live ones or live attenuated could precipitate an episode of TTP. We haven't really seen that. Vaccination is terribly important. And it's probably a bit more relevant for some of the other type of thrombotic microangiopathies and less important for TTP. The caveat to that are the patients with congenital TTP, because vaccinations and viral infections are more likely to precipitate an acute episode, but the majority in the UK are on prophylaxis, so they're already relatively spared. So less of a problem for immune-mediated TTP. However, if you've had rituximab in the last 6 months, you're not probably going to be able to mount an antibody response as well. So it's useful to find out or work out when you last had rituximab, if you've had it, to make sure that you can actually mount an antibody response.
Okay. Next question is, my ADAMTS13 level has been below 1%, but my latest blood draw results show 42% ADAMTS activity, but my body is still producing antibodies. How is this possible?
So it is possible. It would be less likely at an ADAMTS of 42%. There are some patients who have antibodies present. My dog's going to climb on me. Who they're just bystander. So, oh no, don't step on the computer. Sorry. He's gone.
This is live.
I know, sorry. You can have background antibodies normally. So even in normal people, you can have low-level background antibodies. And we've got a couple of patients with completely normal ADAMTS13 who have high antibody levels. So it doesn't necessarily mean pathology, and it depends the level of the antibody. If it's low level, I don't know whether the ADAMTS is going up or coming down, but it'd probably be inversely related to the ADAMTS13 activity level.
Okay. Next question. Platelet drop. Are platelet drop? Oh no, hold on, I've probably missed a word here. Platelet drops in pregnancy normally. I see. So how can you tell if it's TTP and not just normal platelet drop? Does that make sense? Yeah.
Yes, it makes perfect sense. So having a low platelet count in pregnancy is pretty common. And many of so it drops in most women, platelet count, and that's known as gestational thrombocytopenia in pregnancy. You can get an immune type of drop in platelets, ITP. The chances of having TTP are not common, obviously, and it's usually significantly reduced. So, we just see a lot of patients with a reduced platelet count for which there's historic values that are completely normal, and they're not going to keep dropping down to really low levels, so it's monitored. I mean, the chances of you having TTP with a drop in platelets in pregnancy is not high. Okay. Conversely, you need to make sure that it's not TTP, but there are other things that we can do, and we do consider that.
Okay, brilliant, thank you. Next question. How do we know if we're on the TTP registry, or how can we be added if we're not?
So your consultant should know and should have asked you, and you can ask them to be part of it. So we have 40 odd hospitals in the country who are signed up.
Next question. Hi, Dr. Scullly. Thank you for your seminar. I just wondered, what is the longest remission anyone has had after rituximab? Thank you.
Oh, still ongoing since 2004.
Wow. Okay. Next question. Usually rituximab is my main treatment. I have too many reactions after rituximab. How is the new meds will be effective? Do I need blood test or some test if the new treatment will be effective? I am part of the TTP registry.
So some patients do get reactions to rituximab, and they can be pretty awful and life-threatening in very rare situations. So we have started to use another type of anti-CD20, which is what rituximab is. So it's against CD20, which are the B lymphocytes. Rituximab is mouse anti-human. It does not mean that you're all full of mice. It's just the way it's produced. But some of the new ones coming through are human anti-human. It can be a bit more problematic to get them because, as you know, rituximab's not licensed, and they're definitely not licensed. But hopefully, with the new structure in the future, the policy will include all of the anti-CD20s. So if you've had bad reactions to rituximab, and we often check to see if there's antibodies to it, for our patients and around the country, you can alter it to this other human anti-human. So you will get still reactions during the infusion. That's almost normal, as long as it's not a full anaphylaxis. But sometimes patients get quite unwell afterwards with rashes and joint pains and things like that. And it's better that they move on to one of these other types. But it's still quite difficult to get in many places.
Okay, 1 second. Got a question here. Right, next question. How long does rituximab last in the system before the ADAMTS 13 drops again once the ADAMTS stabilised? Which is kind of related, I think, to the question to before about what's the longest remission, but I guess that's more of an average.
Yes. So, I mean, to be honest, everybody's different, and that's why you're monitored. You know, there's some patients who almost are on a clock every 18 months. Others, it might be 2 years, 3 years. It can vary. So, you know, it might be 2 years, 2 years, 4 years. But though we also know that, you know, the reason that we want to continue following up, and that is a 6-monthly appointment, is that it can go out to 8, 9 or 10 years, and then the ADAMTS drops. So it's very, very patient dependent. And there's no fixed amount, but there is a cohort of patients, a small cohort of patients, for which we have to retreat every 2 or 3 years.
Okay. Do all immune-mediated TTP patients with normal ADAMTS and platelets and in remission need aspirin if having gastric side effects from the aspirin? No.
Unless there's another reason, no. I mean, there's no evidence for giving it other than if someone is going to reduce their ADAMTS level, or they've had previous strokes. They're really the main reason to give it.
Okay. So this is a really question. Have you heard that there's a study in the US at the Ohio State, and they're trialing acquired TTP for how they treat congenital TTP, the recombinant version that you were talking about before? Have you heard anything about that?
Well, it's the same study.
That's the same study.
Yeah.
Okay. Next question. Does the recent decision by NICE not to recommend the use of Kaplan, I just call it Kaplan, in TTP mean that this will now not be available for use in relapses?
So it's still patient access program. So we still have access to use Kaplan until the final NICE outcome is presented. Clearly, it was not a good outcome when they said they were not going to support Kaplan. And their main issue really is the long-term benefits of having caplacizumab. As I said earlier, for many years, we were trying to ensure that we get patients through acute TTP. I mean, it was a challenge for a very long time, and to try and improve diagnosis and reduce the death rates, which I think is evident certainly in the UK. It's not that patients don't die, it's just it is reduced. But over the last few years, it's become completely evident, and that's why we've made steps, hopefully, to address this, that the longer term impact of having TTP needs to be considered. We're not going to get information after 2 years doing the registry. This is for the long haul. And, you know, we're looking at 5, 10, 20 years to see the impact of having acute TTP is. And there may be no impact, in as much as it does not affect your, you know, your long-term life outcome. And why should it if you've had just one? But we couldn't give the information to NICE about the impact of Kaplan in the long term because that wasn't the design of the study. Even though we've done the post-Hercules, that hasn't been presented yet. It's only just finishing. So NICE have asked for further comments. I mean, I've been peripherally involved and I've sent my comments back. NHSE, who are involved with the commissioning of the specialist centres. They know that it's very important to ensure all patients get CAPLA. As far as I'm concerned, it's standard of care for all patients, not only in the UK, but also internationally. So we need to wait and see what their next outcome is, which probably will be by the end of July. And I'm really hoping that it'll be a bit more positive.
And I think
I don't know. Go on.
Oh, I was just going to say that it's really good that you explained that, because there is a way that everybody on this call, if you live in the UK, can help with this, because NICE are asking for comments from the public, and particularly the public who are affected by the decision. And so I've been doing a bit of a call to action via the Facebook page for patients to complete the comments section on the NICE website, and I can send it out to you all after this meeting. And it's really for you to give your opinion on what difference you think CAPLA would make if you were to have another episode, and what difference that would make to your life. And the things I've been thinking about that might help you in your thoughts is, given the fact that it can speed up the time your platelets get back to normal, that would mean less plasma exchange. That would mean potentially less time spent in hospital. That might be less time off work. That might be less time with your family. What's the impact of that on you? Would that affect you better psychologically, financially, physically? So if you think CAPLA would be of a benefit, really, really, can you hear me still? Really, really, you do need to, I urge you to send a comment, and you can do that either by emailing me with your comment, and I've been given permission by NICE to forward those emails, and they will read them. Initially last week I didn't know if they would, but they've told me this week they will. Or you can go onto the NICE website and I will send you the link to that, and you can just do comments on, they use a web form. You have to register and put your details in. It's quite simple, but if you don't want to go through that, email me and I will forward your comments. But I think the problem is that they've really not understood the fact that we can't get long-term data, and there is a risk that they won't authorise it for use, and which there's work going on to try and at least have what they call a managed access scheme, but nothing's certain. So we've really got to work as a team and try and influence their decision. And we're such a small group anyway of patients with this condition. The more of us that can speak out by sending in a comment, I think it's got to be of benefit.
So can I just say that there's a number of things that you probably, I don't think maybe it's come over, because there's a lot to say. Firstly, this is the first proper clinical trial in TTP ever. It's been conducted by the book internationally. And secondly, we've been using CAPLA in the country, and for the last 2 years. I know absolutely it has saved patients' lives. And the results that we have as a country are absolutely as we found in the clinical trial. So, the time of plasma exchange is so reduced. You have one line, a few days of plasma exchange. Okay, you've got to give an injection every day when you go home, but it's much nicer than having to be in hospital. And many of you will not have had CAPLA, thankfully, but some of you will have had it, and some of you will have been involved with the clinical trial. It is the biggest breakthrough and change in TTP for 30 years. And it will be an absolute disaster if we cannot have access to this drug for patients who are very sick often when they come in, and can turn around really quickly with this therapy in conjunction with all the other ones. So I plead with you, if you have a voice on this one, please use it. Over to you, Joe. Sorry.
I forgot I'd muted myself. Thank you. Hopefully we put that message across. Okay, we do have more questions. Have you still got time, Marie?
Yeah, keep going.
Okay, keep going. Well, this is testing me. I'm taking azathioprine. Thank you. Does this have a good success rate of pushing the ADAMTS 13 up? I'm something. I think that's one question. It's my error. I was reading on to something else. That's the end of that question. Does that have a good success rate of pushing the ADAMTS 13 up?
So there are a small proportion of patients for whom the treatments that we use do not normalise the ADAMTS 13. That doesn't mean that they're not in a clinical remission, but obviously it's better to be able to monitor them if we can see that the enzyme level is normal, and if it starts decreasing, then we can act. So we do use other treatments. So the main ones are mycophenolate, cyclosporin, which I don't use, but some people do, or azathioprine. Azathioprine is kind of like the mother drug of them all and has been around a long time and is licensed in pregnancy. So we have used it occasionally in pregnancy. It's certainly worth trying to see if it normalises the ADAMTS 13. But, you know, if the levels are really low, it's just some patients have very low levels all the time. As long as they're in a clinical remission, we then just need to guess when to give further therapy to prevent another full-blown relapse.
Brilliant. Are there any TTP centres planned for Scotland?
So the process that we're going through is for England. Not for Scotland, not for Wales, but NHSE have been speaking to their counterparts in both Scotland and Wales, but it's up to the Scottish Health boards to develop a similar system, which I'm sure they will, what's developed in England.
Brilliant. Oh, got a little bit of feed over. Where's that coming from? Can everyone check they're on mute? Not sure where that's coming from. Okay. Okay. Are there any plans for research into how to improve the quality of life post-TTP? Lots of people report they suffer from extreme fatigue and joint problems that significantly affect their life physically and psychologically. Or what can we do to help combat or manage these symptoms?
So, yes, and we take this very seriously, and we may not have an absolute answer. What we do know is that if the ADAMTS 13 starts to drop, patients can certainly feel worse. Tina, I think, discussed about her plans for a study looking at these particular elements, but also I think the thing that will change in the future are how we eventually will be able to run our clinics. So we will have more of the clinical psychologists, neurocognitive assessments. They will become the norm. And they're very important because they can help give us some idea of why these symptoms are ongoing. The lethargy is very difficult. In some patients with treatment, it can normalise, and in some patients, it still remains a really big problem. In the UK and internationally, we are looking to see if we can work out why this is the case, but I have no state-of-the-art answers for it right now, I'm afraid.
Okay. Is Mutafil, again, I don't know if I said that right, is Mutafil effective in preventing relapse after an acute TTP episode?
So that's mycophenolate, or MMF to many of you. What it is good at with rituximab, it works very, very, very well acutely. And there are definitely some patients who are on it, and if you try to reduce it, the ADAMTS starts decreasing. So yes, it is effective. But again, it's not going to be brilliant for everyone. But the reason we use it is to avoid the need for steroids. And I'm not a big fan of cyclosporin, which was has been used in the past, just because the side effect profile is really quite unpleasant. But it works comparably to that. Some people think the cyclosporin might be better than mycophenolate. it has to be tried. It usually causes minimum symptoms, and for some patients, it really does prevent a relapse.
Okay. I had a question. What is recombinant plasma?
I think it's recombinant ADAMT13, not recombinant plasma.
Okay. Well, can you explain what that means? You might have explained it before, but...
Oh, sorry, that's me.
Sorry.
You're asking me.
Yeah,
sorry.
Yeah, sorry. I'm not looking at the screen, am I? I'm looking at the wrong screen.
So
yes, for you.
The ADAMT13, which is the low enzyme in TTP, acutely and congenital TTP much of the time, we currently replace it using plasma because it's in plasma. But so's loads of other proteins that you probably don't need, to be honest. They won't hurt you, but you don't need them. So what's happened is it's been genetically engineered. So when we give the recombinant ADAMT13, that's all we're giving. It's a powder form of the enzyme mixed with water, and all you get is just the pure enzyme and none of the other things that we normally give you in plasma.
Okay. Are there any studies being done to find out what commonalities there are among TTP patients, wondering if it might predict episodes?
So the best thing that we can use for that really is the enzyme levels. There's no other, parameters that patients have that are going to be more likely that they're going to have recurrent potential relapses. So by that, it doesn't mean if you had very severe presentation, you're more likely to have relapses. It doesn't mean if you've got some of the markers suggestive of other autoimmune diseases, even if you don't have the condition, that you're definitely going to have another relapse. So there's nothing otherwise that is predictive that I know about anyway.
And possibly a similar question, but I will ask it. Are you researching what causes TTP?
Always.
Always. Is there a list of hospitals that are on the register for us to look at? I guess that's so you can check if your hospital is on the register.
There's not actually, and probably the reason that I don't think now's the best time to have that list, other than you asking your consultant, is it is going to change shortly with the whole change in the national specification. So there will be definite regional hospitals at that point, for which even if it's not near to you, you will be expected to attend at least once a year, so that we can review all the things we need to do to make sure that all is good, because they have to be able to, and then we as a nation need to make sure that all patients are catered for. So at that point, I think it'll be much easier to document what the hospitals are, if that's okay, if you wouldn't mind waiting just a little bit longer.
Okay, we're coming to the end of the question, so probably just a few more, 5 or 6 maybe. What are the other tests that can be done to rule out TTP in pregnancy rather than just gestational thrombocytopenia?
So the majority, gestational thrombocytopenia is almost completely different. The platelet count's higher than patients who have TTP, firstly. And secondly, it's not just about the platelet count, it's also about patient symptoms and baby growth and previous history. So it's not just about one parameter. So all of those things would be taken into account, rather than looking at a platelet count that's 80,000 and saying, oh my God, I must exclude TTP, which is not likely that it's going to be TTP.
Okay. Is it possible that a TTP can run, inverted commas, in the family, as my mum and me both have ATTP, both diagnosed at a similar age?
Oh, okay. It can run in families, and there are 3 families in the UK where a parent and a child have TTP. It's not going to be common. And in fact, it's not just TTP that's like that. You know, many conditions, both autoimmune and in fact, some of even like the cancer type of conditions, there's a familial element in it in about 5 or 10%. It's not that this is cancer, this is not cancer. I'm just saying that this familial thing happens in about less than 5% of families. And we've looked at to make sure that there's not a genetic background for some of those families, and there does not appear to be an underlying genetic link that makes them more likely to both develop TTP. But it's certainly well recognised familial element, but it's very uncommon once again.
Okay. Okay. Is immune TTP actually congenital TTP? It gets confusing with ITP, immune TTP, and TTP.
Well, we love an acronym. So congenital TTP is when you're born with a deficiency in ADAMTS13, and that's often referred to as CTTP. The trials have used ATTP, so acquired TTP. We use clinically ITTP, which is not dissimilar, you're right, to ITP. So it's all about the T's and the P's. Now, the reason that we use the shortened version is because it's a bit of a mouthful all the time, but also when we're writing. So we use ITTP rather than ATTP because you don't acquire TTP. You don't go out and say, can I have TTP? You develop it because of the immune system just has a bit of a switch that makes you produce antibodies. And so that was decided amongst an international group of us about the nomenclature. Unfortunately, I can't do anything about TTP and ITP, and people do get mixed up with it. And I know many of you have had issues where people will argue with you and say, you've got ITP and you know damn well that you haven't. So what we do to try and circumvent those situations is to give you a letter to say that you have got TTP, this is what it means, and this is who to contact if you have la, 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 la. We can't do anything about ITP, TTP, I'm afraid.
Okay. We might have covered this. Can you predict a possible relapse from the blood analysis?
The routine blood analysis, not. Unless the platelet count's dropped or is significantly dropped from before. And rather we'd try and predict, we'd rather get patients before they relapse. So that's why we try to preempt it by doing the ADAMTS13 testing.
Is there a maximum number of times you can have rituximab?
Not really. So I did worry about this back in the day. And there are risks with it, giving it, you know, really, really frequently. You can get immunodeficiencies. So some of the patients that have had it really frequently, I've, you know, addressed to them my worry about keep having rituximab. They don't want another episode of TTP, and they just want to get it, have it, and then get on with another 18 months to 3 years of their life and not have to worry about it. So we do discuss that after a number of courses.
18 months on, I'm still experiencing peripheral neuropathy. I think I said that right, related to rituximab in my extremities. Is this common after rituximab? No,
it's very uncommon. I think it might be useful to know what other treatments that you received. It's really, really uncommon.
Okay. I had TTP in 2002 when plasma exchange was the only treatment. At that time, we were monitored for 1 year and then discharged with no follow-up ever. Can I still get involved with the registry and maybe get to have some yearly checkups? What should I do? I live in the east of England.
Okay. Yes, I mean, that was how it was back in the day. I mean, nobody really understood it at all. You know, the enzyme was only defined in 2001 and there were so few cases back in 2002. east of England would probably be Cambridge, Addenbrooke's, maybe. So you can ask your GP to have you referred to the team there. I think that's perfectly reasonable.
I think Will would be probably happy to
yes, of
see
course.
you. Yeah. Can people with acquired TTP have a baby with low or no ADAMTS13? If mine never goes up, can I still have children?
If the what goes up?
If the ADAMTS13 is low or never goes up.
That is very challenging. I never say never, except very rarely, but it is quite a challenge. It's not a no.
Okay.
And you need to speak to whoever's looking after you. I mean, it's going to be very difficult because we like to go into pregnancy with a normal ADAMTS13, and you know, often we've treated patients before they plan to get pregnant to ensure that they're covered for that period. Who knows? I mean, with recombinant ADAMTS in the future, that may well be an answer at a guess.
Okay, we are the last 3 questions now, Marie, be pleased to hear. I was diagnosed with ATTP last June and was sent home with a daily 5 milligram folic acid and 75 milligram aspirin.
Yeah.
I was told I'd need to be on both for a couple of years. The folic acid to help mature the red blood cells and the aspirin to help thin the blood, although the dose is small. Although everyone is different, is this a standard discharge treatment?
Yeah, we certainly discharge patients on both of those things. Although that has changed a bit with Kaplan. So if you're on Kaplan on discharge, you won't get aspirin. The folic acid, usually your hemoglobin, which is the last thing to normalise, once it's in the normal range, I just say finish the box, you can stop it, just because most people don't want to take tablets. But there are some patients who've continued on with it and it's not a problem, it's not going to hurt them. With regards to the low dose aspirin, there's no right or wrong. I mean, if you have symptoms, it's probably not worth continuing unless there's an absolute indication, such as heart disease, or if there's been previous evidence of stroke or stroke-like symptoms. But if you're not on it, it doesn't mean that you're going to do worse. The reason I think that it used to be used all the time is before we were able to monitor what happened with patients. So don't forget, back in the day, patients used to have recurrent episodes of TTP. And so it was a good thing to prevent platelet binding, prevents platelets binding together. But we do have ADAMTS13 now, and we can monitor. And if your ADAMTS13 is normal and your platelet count's normal, your blood is not going to be sticky. So at that time, it really becomes a discussion between you and your doctor as to whether to continue or not. If it's not hurting you, it's not going to do you any harm. If it's giving you symptoms, there may be an argument that you could stop it.
Okay. And again, I might not get this pronunciation right. Is it known if NAC is beneficial to people post-TTP?
There'd be no reason to give it post-TTP. So it looked like, this stuff is called NAC, so it's N-acetylcysteine. And you may or may not have heard of it in the past on the telly. It's actually used to treat patients who have drug overdoses, so like paracetamol, because it binds to the drug and helps clear it. So it's quite a cheap medication that's used a lot in emergency departments. So in America a number of years ago, some very clever colleagues found that this NAC reduced the size of the von Willebrand and the stickiness of platelet binding. It's never been proven and hasn't, I think they did do a very small clinical trial and I can't remember if it ever finished. But you wouldn't use it on its own. You certainly wouldn't use it on discharge because it's an IV formulation. But we have used it in patients who've been very, very sick in years gone by. It seems to offer a very good protection when we're trying to get things under control. But you wouldn't have it on discharge after an acute episode.
And this is the very last question. I tried both Mutafil and cyclosporin, not effective to raise my ADAMTS13. Is there any immunosuppressant that can increase the ADAMTS13? And thank you.
So cyclosporin, or you can try it. It's not very nice side effect wise, but you definitely can try it. And like I say, there may just be some patients who either take some time to normalise their ADAMTS13, or it just won't normalise. And there are some of those patients around, and we just have to manage them slightly differently. If the platelet count's normal and you feel okay and your hemoglobin's all right and the LDH is all right, but the ADAMTS13 is still very low, the side effects from some of these medications are not pleasant, and it may well be you just take your chance, have a discussion with your consultant about if and when you need to have other infusions of rituximab at a certain defined time point to prevent relapse.
Thank you very much for answering all of those questions. There was quite a number there, but it felt like it was a nice way to do it, because I think we managed to keep on top of everything. Thank you so much. You'll get a chance to look at the chat yourself, Professor Scullly, because there's so much thanks in there for giving your time for this.
Oh, my pleasure.
Thank you everybody for coming along. And I will be sending you an email with a little evaluation like I always do, but it's really helpful, to check that the Zoom platform is working and that we're not paying for something that's got faults. Last time there was a complaint that there was a background noise, and I'm hoping that's been resolved. But also to ask for your opinions on what else we can do in terms of subject matter or guest speakers, or if you just want a drop in. Now I'm planning the next session to be on, I did write it down and then I've lost it, 3 weeks from now, so I think that's the 21st of July, and the title to be announced. Just got some things to just sort out there, so keep an eye in your inbox for those things. But once again, thank you ever so much, Professor Scullly. Really do appreciate your time and your continuing support for what we do at TTP Network.
My pleasure, honestly, Jo. Thank you as always. And thank you all for your time this evening.
Thank you. Stay safe, everybody. We'll see you again soon.
Bye-bye.
Bye.